So in this lecture we will talk about ventricular tachycardia, as well as we will talk about ventricular fibrillation and different types of shocks, that is cardioversion and defibrillation. All of you must know what the difference between cardioversion and defibrillation, because whenever the answer is going to be shock in the option, they are not going to give you shock as an option. Instead, they will give you two options, cardioversion and defibrillation, and you need to pick the right answer, and we will discuss that too. So first, going towards ventricular tachycardia. Ventricular tachycardia basically means there is an ectopic foci or a re-entry circuit is happening in the ventricle that fires. If that happen, that fires impulse and that depolarizes the ventricle. That is what happened. Instead of what? Instead of SA node, this re-entry circuit will take control and it will depolarizes the ventricle. Okay, there is no impulse that is coming from the SA node, AV bundle, right and left his bundle. This is not happening. Instead, this ectopic foci is firing, and that is too rapid. All right, so as the depolarization happening through ventricular muscles, instead of the normal depolarization that happens through his bundle, right and left his bundle and Purkinje fiber, this is not happening. So what we get wide QRS complex. So we get a wide QRS complex because the conduction is happening through the muscle, and conduction through the muscle, ventricular muscle, is slow, so it take a lot of time. So we get a wide QRS complex. Say this is the normal. In ventricular tachycardia you get a little bit wide, but when the tachycardia when the ventricular tachycardia is so fast, then you may not be able to appreciate this proper QRS complex. It would be something like this. Okay, in the beginning it can be like this wide QRS complex, but as it picks up speed, it would be something like this. I will show you the diagram as well. Okay, so here the one of the feature wide QRS we mentioned, and there is higher, obviously it's a tachycardia, so there is a higher heart rate. Higher heart rate means the RR interval is very short. Now next is the in ventricular tachycardia, the lead AVR will be always positive. Why? Because in ventricular tachycardia, you can see here, this is the ectopic that's firing. Okay, so where is AVR? AVR in here, or almost. Can you see? This is the AVR lead. I will show you. We have discussed this already in our lead placement lecture. Let me show you that. This is the AVR lead. So where is ectopic happening? Ectopic is happening from here. So, and it's throwing current in this direction as well. So it's, see the direction, it's going to be in the direction of AVR. So AVR will record this as positive. So AVR is positive. In all other cases, AVR is negative. Why? It's usually the SA node that fires and current goes down like this. So the AVR will record it as negative. But in ventricular tachycardia, it's not the SA node. So sorry, earlier if I made a mistake, it's the SA node usually fires. So the AVR is negative. The directions are opposite. But in case of ventricular tachycardia, it's the ectopic that's firing. As the ectopic is firing, you can see that it's in the direction of AVR. So AVR will record it as positive. Now about axis. See, this is the ventricular ectopic. It's firing in this direction. So usually the electricity, let me show. Okay, this is the usual thing. See, here is the SA node and it fires. So it usually lie in the normal axis. But in case of ventricular ectopic, the impulse is from up from down to up. Here is the ectopic and it's firing up. So the axis would be here, the axis would be here. From here impulse is firing, so the axis would be here. And which quadrant it is? This one. This is the upper right quadrant, and that belongs to which axis? We have discussed this already. Axis, it comes in the extreme axis or indeterminate axis. So all ventricular tachycardia, you will have extreme axis deviations. You don't need to do the r minus s here. If it is vt, directly you uh, select the option extreme axis. Now I will show you an animation of a ventricular tachycardia. Let's see. So here you will be able to appreciate a ventricular ectopic, and it will be in yellow color, and you will be able to see the impulse generation. Here, look at, can you see that area is bombarding some electrical signals, some impulses, and it's getting really fast now. This is what exactly ventricular tachycardia is. Alright, now we have different types of ventricular tachycardia. That is monomorphic ventricular tachycardia, where these waves will have almost same shape and same amplitude. But there is another variety, that is polymorphic VT, where the amplitudes vary as well as the rate, the rhythm is irregular. Alright, I will let's go to a picture that shows. uh, can you see this? This is ventricular tachycardia, and this is monomorphic ventricular tachycardia. The amplitude is same, okay, and it's definitely it's wide QRS complex. There is no doubt about that. So almost all cases, the ventricular tachycardia, in your case, you will get this sort of shape. All right. You won't be able to see the white QRS very clearly like this. You may not be able to see this. Okay, maybe in the beginning you would be able to appreciate, but later as it gets faster, you will get something like this. Okay, and let's see another picture. Can you see here? This is again another ventricular tachycardia, that is of same amplitude. Right, you can see here this is of because of the same amplitude, and the amplitude is same as well as the rhythm is regular here. And you cannot see any p wave here because the ventricle is the depolarizing very fast. The heart rate, the ventricular activity is so fast, so that you are not able to appreciate the activity in the atria, and you get as well as I mentioned broad QRS complex because the conduction is happening through muscle. Again, T wave is difficult to identify like P wave because of the high ventricular activity. Now let's see another ventricular tachycardia. Yes, it is almost same like this, but the difference here is the amplitude. See, the amplitude is varying, it's decreasing, it's increasing, it's decreasing. And if you look at this distance, that is the QRS complex width, that even changing here. It's the gap is a bit a bit big compared to this. Okay, so the QRS and the heart rate is also like the rhythm is not regular. It's something like atrial fibrillation. All right, so in polymorphic VT, main thing you need to remember is the amplitude keep on changing. All right, so and the ventricular tachycardia, we have two types. One is monomorphic VT, and again, why it is because of it is monomorphic VT, because it's the one foci that is generating the impulse. That is why you are getting all the waves in the same shape. That is monomorphic VT. But in polymorphic VT, see, instead of this one re-entry circuit or foci, there can be multiple foci. Sometimes this would be firing and sometimes this. That is why you are getting different shape. Or there is another possibility, that is this re-entry circuit, it may be traveling. First it's here, then here, then here. It may be moving. That can also give you a different shaped waves. So that is about polymorphic VT. And many of you will have confusion, that is how this polymorphic VT is different from Torsades de Pointis. Well, it's very simple, that Torsades de Pointis means it's definitely it's polymorphic VT, but polymorphic VT that is due to prolonged QT interval, that is called Torsades de Pointis. It's a variety of polymorphic VT. Polymorphic VT that is due to prolonged QT interval, that is Torsades de Pointis. But usually if the ventricular tachycardia is due to polymorphic ventricular tachycardia is due to some other reason other than prolonged QT, it is just general polymorphic VT, and usually it could be because of the ischemia present. Okay, so we have completed the monomorphic VT, polymorphic VT, and it is very important to identify polymorphic VT from monomorphic VT from polymorphic VT. Why? The treatment is different, the medical treatment. Yes, if the patient is unstable, it's going to be shock, no doubt about that. But in case of medical management, yes, monomorphic VT, we try amiodarone or lidocaine or flecainide, whatever it is. But very important thing, if it is polymorphic VT, the medication is not going to be amiodarone, though it is a type of VT. The medication is IV magnesium sulfate. All of you must remember this. There is a difference in medical treatment. And when it comes to when the patient's vital is unstable, collapsed, then it is going to be not the medical treatment, it's going to be shock. All right, so let's go through the treatment of ventricular tachycardia. Okay, so the treatment, if it is unstable, it's shock. If it is stable, you have amiodarone. That is what usually works. But if you want, you can try lignocaine. It shows faster action than amiodarone, but it doesn't work always. And another medication is procainamide or flecainide. No need to remember what's your focus should be here, that in polymorphic VT, if the patient is unstable, first you will give shock, then you will give which medication? It's not amiodarone, it's going to be magnesium sulfate. If the patient is stable, then no shock, you start with IV magnesium sulfate and stop the drug that causing prolonged QT. All right, so this is stable and this is unstable. Okay, stable, basically management, like what's causing this polymorphic VT, stop that and start the patient on IV magnesium sulfate. So if I ask you the management of Torsades de Pointes, the answer is what? It is if the patient is unstable, shock, magnesium sulfate. If the patient is stable, stop the drug causing prolonged QT and IV magnesium sulfate. Start the patient on IV magnesium sulfate. And another important thing you need to remember is that what assessment we do when we start the patient on amiodarone. Well, in emergency case, we give amiodarone, we don't do the assessment. But if the patient is more prone to recurrent ventricular tachycardia, then we will start the patient on long term, right? Long term, I will put the patient on long term amiodarone. But before that, we need to do some tests: thyroid function test, urea electrolyte. Okay, thyroid function test and urea and electrolyte, basically kidney function test. And because this amiodarone can cause some change in electrolyte and low potassium and magnesium, it can increases the arrhythmia. Then just go through this eye examination, chest x-ray, liver function, and why we are doing this, the purpose. Well, if you ask me why we are giving amiodarone here and in monomorphic VT, and why not in polymorphic VT, why we are trying magnesium sulfate instead of amiodarone, because the amiodarone itself can cause long QT. So if that is causing long QT, would you consider amiodarone for polymorphic VT? No. One of the cause for polymorphic VT is long QT, so we don't give it. Well, the long QT could be because of two causes. One could be it's congenital, because of some channelopathy, some channel defect. The patient can have long QT, or it could be acquired. Acquired means because of some medications and because of some electrolyte dysfunction or because of some medication that causes prolonged QT and polymorphic VT. And important one is that an antibiotic called clarithromycin and antidepressant like citalopram and haloperidol. You need to remember the name of these drugs, as well as some electrolyte dysfunction like all are hypomagnesemia, hypokalemia, and hypocalcemia. And our next discussion is about ventricular fibrillation. It's due to multiple re-entry tract. Unlike one re-entry tract that we saw in monomorphic VT, here we have multiple re-entry tract, and the re-entry tract is more than. We discussed that polymorphic VT could also due to multiple re-entry tract, but here the re-entry tract is too many, right? And it can all fire at the same time, so definitely the heart rate is going to be different. Let's see an animation to understand it better. See, the yellow one is the 4K, yellow or green color. That one is the 4K, and now it's going to start fire. Let's look at this. Can you see there are multiple areas that's firing at the same time or at different time? All of them are firing, and this is what exactly ventricular fibrillation. Since there are multiple re-entry circuit, the amplitude can be different, and the rhythm can be irregular, so we get something like this. Can you see the amplitude is regular, means irregular, sorry, the rhythm is irregular and amplitude is varying. Can you see here it is the height of these waves are different. This is too high compared to this that height is very less. And one more thing we notice is that the amplitude is it's less compared to polymorphic VT. Where is I will show you the diagram of polymorphic VT, which we already discussed. See, this is also irregular, but amplitude wise this ventricular fibrillation, this is the amplitude is less, as well as there is no pulse. Pulse is always absent in ventricular fibrillation, but in ventricular tachycardia, the this one, that is polymorphous ventricular tachycardia, it could present with pulse, or the pulse can be absent. So that is the difference, and I completely understand that it is sometimes difficult to understand this polymorphic VT as well as ventricular fibrillation. Remember, if it is polymorphic VT, they might have given you some antibiotic or some drugs that causes prolonged QT, or a baseline ECG that showing the patient had prolonged QT. Okay, so that's it, our discussion ventricular fibrillation. This is how it appears, and we have discussed some of the images of ventricular tachycardia and ventricular tachycardia, monomorphous ventricular tachycardia, how polymorphic ventricular tachycardia appears, polymorphic ventricular tachycardia, and ventricular fibrillation. Okay, ventricular fibrillation. Well, ventricular fibrillation is more irregular compared to polymorphous ventricular tachycardia. Now again, coming to the management, if it is ventricular fibrillation, if the patient won't have any pulse, so he is definitely is going to be unstable, so the treatment is going to be shock, and that's the treatment. So my question here is, this was a question I asked in the beginning, like, how do you know whether you have to give shock in the form of cardioversion or defibrillation? Shocks, we have two types. One is synchronized shock and another is defibrillation. I mean, synchronized shock basically means cardioversion, and random, giving shock random, that is non-synchronized, is called defibrillation. What does it mean by synchronized? Synchronized means you give shock around when R wave is happening. If you give shock at that time, that is called cardioversion. If you are giving shock at random point, random time, you are not waiting for the R wave to happen, you are just giving shock, that is called defibrillation. Now, where you give cardioversion, all cases arrhythmia, you give shock in the form of cardioversion. If the patient is having pulse, if the patient is not having any pulse, no pulse cases, where you get no pulse, in which arrhythmia you get in ventricular fibrillation, definitely I told you there is no pulse. Or if there is a ventricular tachycardia without pulse, without pulse, then also you give defibrillation, that is non synchronized shock. For now, for some of you who have not yet watched my old videos, uh, or those who are not having a good cardiology basics, so actually, what prolonged QT interval means? See, first of all, we prolonged QT means prolonged QT interval. What is that? It is the distance between the start of Q wave and end of T wave. That is QT interval. This one, and you see, this is QT interval. And what is a normal QT interval? It should be like between 9 to 11 small box. Again, we have discussed details about the large box and small box. This is one small box. Like that, this distance should be within 11 box. One box is 40 millisecond. All of you know. So 11 small box means it should be less than 440 millisecond. It depends on gender. uh, it can be up to 460 millisecond. So doesn't matter, it can be 11 small box, up to 12 small box is acceptable, but more than 12 box, definitely it's prolonged QT. So people with prolonged QT, they have a tendency to uh, develop these arrhythmias, especially polymorphous, sorry, a type of polymorphous ventricular tachycardia, that is torsades de pointes. So in here, if you look at this one, here is the point where Q starts, here it ends. If we count number of small boxes, 1 2 3 4 5 6 7 8 9 10 11 12, it's definitely more than 12, 13 14 15 16, almost 16 small box. What is the maximum? 11 to 12 box. This is 16, so this is long QT interval, prolonged QT. So patient with this ECG, they can anytime develop torsades de pointes, a type of polymorphous VT. So they can have what? They can have a recurrent fainting attack. This is how the MCQ come. Fainting attack. A patient is having recurrent fainting attack. An ECG was taken, and the ECG is with you. And when you look at the ECG, you are not seeing the prolonged. You are not seeing the polymorphous or arrhythmia or torsades de pointes. You are seeing just prolonged QT. So what actually happening is that this patient is developing recurrent VT because of recurrent polymorphous ventricular tachycardia because of his prolonged QT. Now let's look at a full lead ECG. So let's like lead to, if you look at here, this is where the Q wave starting. Am I right? And where is this is the T wave, and where is T wave is ending almost here. So this is 1 2 3, almost 4 large box. See, inside these boxes, each of them, there are small boxes. Okay. So for large boxes, 4 means 20. One large box has got 5 small square. So 20 small square, definitely more than 12. So again, it's prolonged QT interval. So if an ECG is given and the patient had episodes of fainting attack, you need to consider two things that are very important. One is heart block. So you need to check the PR interval and or missing QRS. Again, this is a separate video. And another thing is this one, prolonged QT. Obviously, you need to check other aspects like whether it is SVT, what else it could be. Yes, AFib, but definitely you should look for prolonged QT and heart block and prolonged QT. Okay. Heart block again I will discuss in separate lecture. So that's it, the last part for the people who are new to my video and haven't watched the old videos where I have exactly told you the basics of ECG, everything, P wave, normal, high, T wave, everything we have discussed in detail in that video. So you can go and watch that video.